Okay, so let's look at the gastric pathology. We're first going to deal with few embryological disorders. There are four main ones which you're supposed to know. Okay, the first one is gastroschisis, then omphalocele, congenital umbilical hernia, and hypertrophic pyloric stenosis. So the first one is gastroschisis. So in this defect, there is a defect in the closure of the lateral body folds. Okay, so during development, there are four body folds forming. Okay, there are two lateral body folds which are coming like this and fusing to form the anterior abdominal wall. When there is a problem with this fusion, okay, there is this cut-like thing which is forming on the anterior abdominal wall through which the bowel loops come out like this. So now the important thing which you're supposed to note over here is it is not through the umbilicus. Look, the umbilicus is right over here and the bowel loops coming adjacent to it. Okay, so it is not covered by amnion. It is not covered by amnion. The second one is omphalocele. In omphalocele, what is happening is the herniated midgut loops are not going back. So now what is happening during development is the loops herniate outside. It's like this. Assume this is the abdominal cavity and this is the umbilical cord. Okay, and this is the head end of the fetus. So what happens is the developing liver and all this, they just push out the midgut loops like this, as there is no space inside, and the midgut loops lie over here in the umbilical cord. Later on during development, when the fetus grows and there is sufficient size in the umbilical cavity, like the abdominal cavity like this, these come back over here, the midgut loops come back. Whenever there is failure in these structures returning back, this is when omphalocele occurs like this. As it is through the umbilical cord, it is covered by this grayish thing, the whole grayish thing which you can see, it is covered by that grayish thing. Unlike in gastroschisis where it is not covered with anything, in omphalocele it is covered with this grayish amniotic layer. And the third one is congenital umbilical hernia. In this, the umbilicus just fails to close properly like this. It just fails, and the small loop coming out, but the important thing is it is covered with skin over here. You look, there is skin, unlike in omphalocele and gastroschisis where there is no skin. But this is a very small defect and it's not a big problem. The next one is hypertrophic pyloric stenosis. Now pyloric stenosis. Now what is pyloric sphincter? It is nothing but smooth muscle which regulates the flow from the pylorus into the duodenum. So whenever this is stenosed, okay, why is the stenosis happening? It is because there is hypertrophy of the muscle. So because of this hypertrophy, there is something blocking the food from going from the pylorus of the stomach into the duodenum. So what happens? Now assume this is the pylorus, this is the sphincter over here, and this is the duodenum. Now this pylorus is so much like hypertrophied, so the food is not going in, so the food goes out, so the baby vomits out everything. The bile enters the duodenum, so as there is no passage for bile, the vomiting is usually non-bilious. Okay, and what you have to remember is male and macrolides. The first male child who has in utero exposure to macrolides is prone to develop hypertrophic pyloric stenosis. Now when something is in excess, what do? You just remove it. So the treatment is myotomy, just cut off the muscle. It is as simple as it is.